Anyway, so hello there, my name's Dr. Danielle Arabena. First of all, I'd like to acknowledge the traditional owners of the land on which we stand today and the ancestors past and present. I'd also like to acknowledge the other Aboriginal and Torres Strait Islander people in the room, my colleagues of cultural mentors, cultural educators, and I'd also like to acknowledge the CEO of Australia, CEO of the Australian Indigenous Doctors Association, Craig Dukes. I'd also like to acknowledge Dr. Carly Hayward. She was down to Penn to present this for us. She's got sorry business today, but she's the president of AIDA. And I'm just like the backup girl, you know, like the do-up girl who's the background who's suddenly been called forward. So a bit about myself. I'm from Miriam Mer descent. I grew up in Brisbane, and my father left Torres Strait, went to Cairns and then moved down to Brisbane and met my mother. Today I'm going to talk about an AIDA initiative. We're actually developing a clinically based cultural safety training education program. And I'll talk to you about a bit around cultural safety and why it's so important, and provide an overview of the work AIDA is doing in this area. So AIDA is a not-for-profit membership association. Who's heard of AIDA? Anybody? Who's members? Come on, you fellas. Oh, well done, thank you. So we're based in Canberra. We have a Canberra-based secretariat. Our work aims to contribute to equitable health and life outcomes for Aboriginal and Torres Strait Islander people. Our goal is to reach population parity of Indigenous doctors. Now, who would like to hazard a guess how many doctors we need to get that population parity? How many more Indigenous doctors do we need to produce? Michael? Close. Double. 2,500 doctors we need to get population parity immediately. We inform and support a culturally safe healthcare environment through a unique perspective for the health of our people. We maintain and value the links between traditional and contemporary medicine through having close collaborative relationships with traditional healers, such as the Ngangkari from the Central Australia. We work from an empowerment, strength-based perspective, and we provide input into high level of public policy. So the AIDA story so far. So back in 1997, there was a group of Aboriginal and Torres Strait Islander doctors and medical students who were hanging around in Salamander Bay, and they suddenly realised that they had a unique voice and a unique perspective to put forward to Australia. So AIDA was born. In 1998, AIDA was established. In 2001, the Secretariat was established in Canberra. In 2005, we had a collaboration agreement with the Medical Deans of Australia and New Zealand. 2008, we registered as a company. 2010, we were up for the Indigenous Governance Award finalists. In 2012, we hosted PRIDOC, which is the Pacific Rim Indigenous Doctors Congress, and we signed a collaboration agreement with CPMEC. In 2013, we had a collaboration agreement with what are they called? Committee of Presidents of Medical Conferences. So Congress. College. There you go, writing, doctor's writing. We renewed the collaboration agreement with the Medical Deans of Australia and New Zealand in 2015. So why is culture so important? Culture has always been and continues to be a source of strength, resilience and well-being, identity and confidence for Aboriginal and Torres Strait Islander people. Each of these factors are linked to health and well-being, making the protection and promotion of cultural experiences critical to processing improvements in our health. Culture will define who we are, how we think, and what values we hold. We learn through our experiences of our culture and spirituality every day. And we learn through our families, and also through trauma and suffering that we've experienced through colonisation and the impacts it has had, through inherently racist policies and practices. So cultural safety is about acknowledging and understanding and overcoming our power imbalances. So many of you know the statistics that led to the government's commitment to close the gap. Aboriginal and Torres Strait Islander people have experienced a disproportionate burden of illness and social disadvantage when compared to non-Indigenous people. Because of this imbalance, I'm just reading this slide. Cultural safety in the context of Aboriginal and Torres Strait Islander health is about acknowledging, understanding and overcoming the cultural power imbalances of places, people and policies. Cultural safety is a concept first that was developed by the Maori healthcare context and around the 1990s. The aim is to address the way the colonial processes and structures, including racism, shape the outcomes for Aboriginal and Torres Strait Islander people. When applied to an AIDA context, specifically when it's about increasing numbers within and supporting the Aboriginal and Torres Strait Islander medical workforce. So what are the benefits? Evidence shows that Aboriginal and Torres Strait Islander people are more likely to access and will experience better outcomes from services that are respectful and culturally safe. So many of you might know Associate Professor Noel Heyman, who back around 20 years ago started working at Inala Indigenous Health Clinic. He had 12 patients when he started, and he did consultation with the community and started reviewing what he needs to do to change the practice to get more Aboriginal and Torres Strait Islander people accessing the health service. So what they did is looked at ways that they could make it a more culturally safe environment. They added Aboriginal and Torres Strait Islander artwork. They got identifiable Aboriginal and Torres Strait Islander staff. And through that consultation with the community, over the 20 years it's now grown. He's got the Indigenous Centre of Excellence, is what it's called, out at Inala, and it's basically almost like a hospital. He's got further funding, billions of dollars have been thrown at him to make an exceptional service for Aboriginal and Torres Strait Islander people nationally. So I think on the books he's got about 6,000 patients now. So we know that that sort of stuff works. So we are improving the health outcomes based on respect and inclusion. So given the levels of health disparity and our efforts towards cultural safety, we've got to look at different ways of teaching it. And so this is where we're coming into it. How can a culturally safe health system be achieved? So it needs to be part of the entire system. It needs to be embedded in all levels of our policies, practices and places to ensure greater access to healthcare, sort of what Noel was doing. And we need to work together on cultural safety because as becoming an integral part of health education, training curriculum and workforce development and having a service provision. So I want to talk about what the point of difference is really around AIDA. And we have some core strengths around this. We have a unique perspective on health for Aboriginal and Torres Strait Islanders. We know the gaps, and our doctors have experience as both providers and consumers in the health system. We have a strong cultural compass through our membership, our networks, through our links to community, through our links to traditional healers. So what AIDA started thinking about a couple of years ago is developing a cultural safety training program which would assist doctors, practice managers, nurses and employees across the healthcare sector to educate and train health practitioners to participate in culturally safe ways when interacting and treating Aboriginal and Torres Strait Islander people. So it will be developed by Aboriginal and Torres Strait Islander doctors. We know the health system from the perspective of a practitioner and a consumer. We've been educated in the system, and so we know where the racist and the bias lay. Our families use the system, and we've seen that where the gaps are, and we have strategies to address them. I just want to segue back to when I was a medical student. There was two big points that stood out to me. One, we were standing, we're doing clinical coaching, and I was standing by the bed of an Aboriginal man, and I've got 3 examples to tell you. And the clinical coach said the gentleman had pancreatitis, and he said, now because he's an alcoholic, that's why he's got pancreatitis. And I could hear the gentleman saying, but I don't drink. And he kept overriding him and saying, now because he was an Aboriginal, and this, this was happening 10 years ago, and this is what our other medical students are being indoctrinated into, this sort of system where we have, it's still a bit of racism and bias in the system. Another time is when I did my medical exam, our sort of end of year exam. There was an Aboriginal person, and they were talking about, he had deranged liver function tests. And I remember thinking, I was asking all questions around, is there overcrowding? Is there, what's going on? Who does he live with? And I was getting down, it was like, no, no, no. And I got to the end and I was like, please don't be about grog. Please don't be related to alcohol. And it was, he had an alcoholic, liver condition. And I remember I went up to one of the facilitators afterwards and I said, but why did the person have to be Aboriginal? There was no other context in there. There was nothing else related to the history. Why did you make him Aboriginal? And so this is an experience that other doctors, we learn in that system, and this is what we, know, like it becomes something that's true. And I just want to share another little story that's I've been reflecting on a lot lately, and it was when I was on the consultant liaison team for psych, and I was with an Aboriginal woman, and we were going to see her, and my registrar said, she hasn't been successful in committing suicide, but she's tried a lot. And when I got there and listened to this woman's story, she was in a state of distress, and she was crying, and she said, I keep hearing footsteps. I keep hearing these footsteps coming up to me, and my family always find me just before it's time, like before she's been successful in committing suicide, and they always come to her and she hears voices, whispering. Is there something wrong with me? Have I got schizophrenia? And my registrar said, you do have psychosis, and here's some pills. And when I went outside and I spoke to this fella and I said, you know what? From my point of view, that's her mob talking to her. That's her ancestors coming to look out for her. I'm just getting tingles then. But, for me, that's what it was. There was a different context to what she was experiencing. And I think that that's what we need to understand. And this is the point of difference AIDA, as Aboriginal and Torres Strait Islander doctors, can show you fellas when we roll out these modules that I'm just about to show you. That there are subtle nuances that need to be taught in education that's not. And it's, I'm one little voice on one little team. And imagine if we had that effect going sideways and spreading out, that more and more people would understand that there's better ways to communicate and treat Aboriginal and Torres Strait Islander patients. So AIDA's been working on developing these modules. And so we've got a cultural safety group that have been developing it, and we're going to have a look at what's behind these models. For example, these modules will look at what's behind the missed appointment. So people aren't turning up to things just because they're slack. There's lots of other reasons. When I worked at Redcliffe Hospital, a lot of Aboriginal and Torres Strait Islander people wouldn't come to the hospital. They called it Dead Cliff because you'd go there to die. So they don't want to know they're sick. They don't want to turn up because they're worried that they're going to die. So you can read those. So module 1 and 2, this is where we link into the community. So we'll have, similar to what you've had today, we'll go through the proper protocol around Welcome to Country. And we'll build a cultural context based on case studies as well. Section 2 would be looking at your own cultural biases and creating a safe space to allow the participant to complete and reflect upon their own understanding of culture and what's maybe their unconscious cultural bias. And we've got to think about cultural bias in terms of, what we learnt at med school as well. Some people need to unpack what they know because it goes against their grain, yet they have their consultant acting in a certain way. And we all know to get through things, we need to mimic and respond to what's being taught. There's another example, I've got lots of examples. Another example, we had to do a presentation on a paper, and I wanted to do something on Aboriginal and Torres Strait Islander health, and my consultant rolled his eyes and said it's been done to death. So out of spite, I did it on vaginas because he didn't like those either. So I sort of stuck it to him a little bit. Imagine if I did it on Indigenous vaginas, my goodness. You can tell Carly I said vagina in my talk too, she'll love that. So Module 3 will really go into depth around what's behind the missed appointment, exploring stereotypes in the health setting. So anyone knows that your work's always going to be a bit slower when it's raining, like if you work in an AMS or something like that, because it is, it's difficult for people to get to it. And it's not because they're laying in bed having a sleep in, it might be because transport's difficult. There's a lot of other reasons behind it. So also discharging against medical advice would be something that we would be exploring, and cultural considerations in the consulting room. So who here knows Jeffrey Gurrumal? He's a singer, Aboriginal singer, well, we all know. So I think it was this year or maybe a couple of years ago in Darwin Hospital. I might get my Darwin friends. This year, he was assessed as a drunk, waiting in the... Oh, do you want to tell the story? Go on. Shane, can we have the microphone? Not long. 2 pages. This is only a quick story, but I'd prefer to hear it from someone in Darwin.
My name's Normy, I'm from Darwin, MTGP. Jeffrey Gurrumal was hospitalised because he's got a kidney condition. But in a nutshell, he was in there sick and he was delayed treatment. And then the health minister turned around because Jeffrey, his manager, labelled the hospital staff racist because they weren't giving him the proper treatment, which was delayed, which is something that could have got fixed sooner than what it was. Anyway, so they made a complaint. They went to the newspaper, and the health minister responded predictably, said this is all lies, and he said that Gurrumal was just using it as a publicity stunt to get publicity for his upcoming album that was coming from the health minister, who I can gladly say is kicked out. He's the guy in charge of Four Corners with all the youth detention centre problems. So that guy's gone. He's gone from the territory forever. Good
riddance too. But see, that's, we've got a nationally recognised person who's, going into renal failure and is just being put off treatment, delayed treatment, because it's assumed he's drunk. So section 4 and 5, we'll be looking at clinical cases based around diabetes and including our traditional understandings around that. Cultural 5 would be looking at men's and women's business. Because I often get registrars, asking me, is it okay if they do pap smears? Do we look, Aboriginal people in the eye? So there's all those sorts of questions that our cultural mentors and cultural educators would also be able to talk to. But we would be doing it from a clinical perspective and giving you a rundown on how to do that. Integration into practice is then how do we work that into practice? So for GPs, we'd be talking a lot around the 7-1 for how to do an Indigenous health check, how to do access the EPCs, because a lot of people don't know how to get your practices up and running and making sure that they're clinically safe. How do we identify Aboriginal and Torres Strait Islander people? So what can you do now? So before these modules come out, I ask you to start reflecting on, what's happening in your practice. Is your practice Indigenous friendly? What's the language used? What are you teaching your registrars? How do you role model for your registrars? Are you developing partnerships? Are you talking to local community elders? Are you engaging with your cultural mentors and cultural educators? So quite often we get our local elders and we buy them fish and chips. We sit down and have a yarn with them. So that's what we do as a practice. We look out and see when we have our national sorry days, or try and link into NAIDOC activities, and we'll advertise those in our clinics. And I work in a private practice, so that's things that you can do. So stay active, involved, and speak up. And so if you want to know more, just you can contact us at the policy at AIDA. These modules will be being worked on next year. We've got a pretty impressive working party of, the brains trust of Australian Aboriginal and Torres Strait Islander health. And we've also got our conference coming up in 2 weeks in Cairns. So every year AIDA will have a conference, and if you're not a member of AIDA, please consider joining. You can be an associate member as well. It's a very good support, and we support our young medical students coming through. Thank you.